Hi, I'm Caroline Evendon, and welcome to 10-Minute Medicine. I'm going to be talking about what to do when you're asked to see an acutely swollen joint. So, this is the case. There's a 75-year-old male who's currently on the ward for an infected diabetic foot ulcer, and you're bleeped on call by the nurse saying he now has a hot, swollen left knee. And their key past medical history is they have rheumatoid arthritis, type 2 diabetes, and diabetic leg ulcers. So, first, just thinking about what things this could be. The main thing you want to rule out in an acutely swollen joint is septic arthritis. That's the most dangerous thing, and that's the thing that you're going to need to treat quickly. But other things this could be, it could be a reactive arthritis from an infection elsewhere. It could be an enteropathic arthritis if there's someone, for example, who has IBD. This patient has rheumatoid arthritis. It could be a gout or a pseudo gout. It's very common, and particularly in elderly patients, patients with CKD on the ward asked a lot of times to see an acutely swollen joint, and we treat it as septic arthritis, obviously, but it ends up being gout. And they could also have had an injury to the knee, and it could just be swollen from blood going into the joint. So these are key elements in this history that makes you think that you need to see this patient right away. Is that they've got hot swollen joints, they've got a background of rheumatoid arthritis, so they have a joint that is abnormal and they're most likely immunosuppressed. They also have type 2 diabetes, so they're at high risk of getting infections, and they already have an infection, so they're being treated for an infected leg ulcer. So these all make you think that this could be a septic arthritis. So just to think about the risk factors for septic arthritis. So anyone who is immunosuppressed, this could be from medication, this could be from diseases, for example, HIV. Someone with type 2 diabetes, any abnormalities to the joint. This could be if they've had a hip replacement, if they've got osteoarthritis, rheumatoid arthritis, but also anything that's going to introduce an infection. For example, if they've had an injury, they're an IV drug user, they have current infections, ulcers, and steroid injections into the joints. So, when you see this patient, what do you want to know? You need to know when this happened. If this joint started swelling a week ago, 2 weeks ago, then you're going to be less worried than if this joint started swelling 5 hours ago, 12 hours ago. Where is the swelling? Which joint is affected? And is the swelling, for example, not actually involving the joint at all? And did anything happen? Did they have trauma to the joint? It might be that they fell over and got a big cut on their leg, and that's introduced an infection. They might just have had surgery on their knee. All these things would make you think maybe an infection has been introduced and it's septic arthritis. Anything make it better or worse? And their weight bearing status. If someone has got an acutely swollen knee and can't weight bear at all, there's also your higher risk of it being septic arthritis. So they have other symptoms that make you think an infection. Have they got a fever? Have they had this before? If they've had recurrent episodes of an acutely swollen knee over the past year, then you would think maybe this is gout. Maybe this could be another disease that isn't septic arthritis. Any past medical history, for example, what we've talked about, type 2 diabetes, any medications, so any medications that would make you think, okay, they're immunosuppressed, is this septic arthritis? Or medications, for example, diuretics, that could be something like gout. So you've been to the patient, you've got a bit of a history of what's gone on about their knee. Then you're going to examine it. This patient could be acutely unwell. We're going to treat this as the patient's acutely unwell, and you always deal with that situation with an A to E. And even though you've been asked to look at the knee, you want to look at everything. So you do your A to E. And once you get to the point where you're going to look at the knee, you just use the simple look, feel, move. So you're looking at it. Is there redness? Is there swelling? Do they have, for example, cellulitis over the joint? You also always want to compare to the other knee. They might have bilateral swollen knees. That might be how their knee looks. You also want to look always at the joint above and below. Are they affected? And have a feel where is the pain when you press? Are you able to passively move it? Is there an effusion? And see how much moving they can do by themselves. For example, can they walk on it? So next, you've taken a bit of a history from the patient. You've had a look at their knee. What investigations are you going to order? So if you're thinking septic arthritis, you're obviously going to do the sepsis 6. You're going to treat this acutely swollen joint as septic arthritis until proven otherwise. So you're going to want to get some bloods. You want to get a full blood count to check if their white cell count's raised. Also, they might have had bleeding into the joint. You would want to check their hemoglobin, check their CRP. You want to get their U's and E's. For example, they might have an AKI because they're dehydrated. You also need to know their renal function if you're going to start them on IV antibiotics. The same reason why you're getting LFTs. A urate level very helpful to rule out or rule in gout. And because they have an infection, they might have an infection. Also, it's really important to get blood cultures because that infection might have spread elsewhere if they're septic. And a VBG is very helpful in an acute instance. Whenever a patient is ill and you're doing an A2E, always get a VBG because then you can, for example, look at their lactate, you can look at their hemoglobin, you can look at their potassium. And you would consider getting an X-ray of the joint. They might have had an injury to the joint, there might be a fracture. You would want to rule out a fracture, you'd want to rule out any degeneration or anything else that could be causing this. And then the key thing that is going to prove if it's septic arthritis or not is you're going to aspirate it. So you're going to send this aspiration for crystal microscopy, gram staining, culture, and sensitivity. And this will help you also identify other things, for example, like gout. But if there is cellulitis over this joint, do not aspirate it because then you might introduce an infection into the joint. So that's a really important thing about aspirating. You can aspirate on the ward. If you're on a TNO job, you'll probably do lots of aspirations. You'll see one and then realize it's quite an easy thing to do. And then on the joint aspirate that comes back, I'm sure you've all seen this at med school. I probably don't need to go through this. But if you're looking at septic arthritis, it's going to be a very high white cell count, high neutrophils, and it's going to look infected when you aspirate that joint. So you've done the investigations. How are you going to manage them? You're going to treat it as sepsis 6. So you've taken your lactate. We're going to measure the urine output. And you've taken your blood cultures. You need to get IV antibiotics in as per trust policy, whatever the guidelines at your trust are for antibiotics. You're going to get fluids up. You're going to give oxygen. If they always say that in the sepsis 6, but obviously if their sats are fine, then you're probably not going to give oxygen. So if you're on a TNO job, you would just inform your reg. If you're not on a TNO job, you would need to let TNO know that you think someone has septic arthritis, because after the IV antibiotics, the definitive management would be to go to theatre for a surgical washout. But there are certain instances where that wouldn't be appropriate. For example, patients that aren't appropriate for surgery. So the other thing you need to consider is it is a bit different to manage if it's a prosthetic joint. So having a prosthetic joint puts you at high risk of getting septic arthritis, for example, straight after the surgery, but also later down the line. And this is a high risk of septic arthritis because you've got metal in the joint. It will cause a film. So IV antibiotics are not going to get rid of the film that's created of bacteria. So they have to go to theatre. This would either be for a DARE, which is debridement and implant retention, or revision of the joint. This would be obviously completely decided by the TNO consultants. It depends on when the surgery was done, how fit the patient is, how they're coping, and how septic they are. Depends on when they go to surgery and what they're going to go to surgery for. But the main thing you need to know as a junior on TNO is that you can't aspirate a prosthetic joint on the ward. Well, you definitely couldn't at my hospital. You had to go to theatre under a sterile environment because you're at risk of putting an infection into the knee, especially if there isn't an infection already there.